My name is Howard Straker. I'm a faculty member in the School of Medicine and Health Sciences and also in the Milken Institute School of Public Health. And I'll be moderating our next session. But first, as I thank Dr. Matthew, I want to just kind of she really established a great basis for our conversation, because she made the connection between health and education. And as we're talking about equity, we can't get to health equity in terms of health professions without connecting to equity in the whole society and the underlying inequities that exist. So the next panel is, our first panel actually, is entitled Creating Better Educational Pathways. And this year has been a national awakening or awareness, particularly outside of communities of color, in the use and understanding of systemic or use of the word and the understanding of systemic and structural racism, as Dean Matthew just talked about. In this session, we're going to look at educational pathways toward equity in health professions. The racial inequities in health professions stem from these embedded racism that she was just talking about. It's grounded in the history of housing discrimination and redlining, in educational segregation and discrimination, in economic oppression, and also in cultural hegemony. So to address this, we must overcome racism wherever we are, and activities and policies that increase diversity in our professions are one such effort. So our panelists today are involved in this work. So it's our intent that after this panel is over, you'll be able to explain the importance and the role of educational pathways in health professions education. We want you to be able to identify ways in which educational pathways can be created and improved to support students of color. And ultimately, we want you to find ways to apply these learnings in whatever sphere you are operating in. We'll begin by having our panelists tell us something about their work, some of their work, which covers various or different steps in the continuum, the educational continuum in health professions. Our speakers, in the order in which they're going to be presenting today, is Dr. Bridget Carter, who is an associate professor and is the associate dean for diversity and inclusion at the Duke University School of Nursing. Dr. Telemontes, who is the Chief Operating Officer for AltaMed Health Services, which is in California. And he's also the co-founder of MeMentor.org, which is a national online mentoring organization. And Dr. Demetra Rankin, who is the Associate Dean for Admissions and Associate Professor of Anesthesiology at the Ohio State University College of Medicine. And our last but not least is Dr. Romero Legat, who is the Vice Chancellor of Diversity and Inclusion Executive Officer. And she's a professor of family and community medicine at the University of New Mexico Health Science Center. You can read more of their bios on our website at the Fitzmullen Institute website. And I'm just going to tell you a little about how this is going to operate. Each panelist will start with a small presentation. We'll then have a question and answer period. You can ask questions to the panelists and you do so by putting it in the question and answer feature on the screen. We will then, after they speak, we will entertain some of the questions and answers, and then we are going to move on to the rest of the day. So remember to use your question and answers period. We know we're not going to get to all of you, but we will try to get to as many as possible. And so with that, we're going to start with Dr. Carter.
All right, thank you so much. And I'm going to be talking a little bit today about pipeline programs and how these strategies can really support and improve our ability to recruit diverse students. Next slide, please. I have no conflict of interest. Next slide. And also just want to acknowledge the Nursing Workforce Diversity Program at HRSA, who has supported our programs. Next slide. So our programs right now, again, when we think about developing pipeline programs, we really have to first think about the institutions that we are connecting with. So I have really relied heavily on our HBCUs, or historically Black colleges and universities, and really established advocates within those institutions. And one of the most important things I think we have done there is created mentoring opportunities for those students at those institutions, and really made sure that that has stayed there year after year after year. So this is not something that we do and leave. These students are part of our community now. We start with them in their freshman year, and they stay with us until they actually make application into some institution of higher education, or whether that's School of Medicine, nursing, PT, PA, it doesn't matter. Next slide, please. These are just some of the institutions that we work with. I don't get the opportunity to visit each one of these schools every year. Next slide, please. But there are many other ways that you can communicate with schools. While I may do an annual visit to Spelman and Morehouse and Clark, then the next year I may go to Xavier. I do a rotation. But I will tell you, the secret to this is my students. My students are the ones that actually communicate about our program. They're our voice. They are the ones that recruit for us. We do a lot of emails. We do FaceTime with our students. We do Zoom meetings with our students. A lot of social media. Our students do social media. Whenever we do visits, they get that information out there. And then also, once we meet with our students, you'll go to the next slide, please. We do a lot of print and promotional material, and we put those students' faces on that material and send that back to the schools. And then the schools, when they have additional promotional materials within the school, they include this material as well. So they love seeing their students in these print materials. The students love being in it. They're on our website, they're in videos. So this is one of the ways we're able to get this information out, and it's very low cost for our community. Next slide, please. So one of the things we have to address in terms of pipeline programs, of course, are our barriers to success. And one of the things, of course, for a Duke University is scholarship support. So we have to think about what the institutional support and commitment is to that. When I first arrived at Duke, one of the things we always had to think about is a Eurocentric type curriculum and the dominant culture of being at a predominantly white university. Addressing sense of belonging, isolation, loneliness. Many of our students have family demands. They had to, whether that was to their sisters, to their mothers, or to any other children, we had to think about how to support them. And then there was a lack of BIPOC faculty, Black and Indigenous and other people of color for role models. So those are the things that we addressed in terms of our strategy. So we tried to identify those faculty and peer mentors early. We made sure that we created affinity groups that supported those diverse students. We provided a free tutoring program to make sure that they had that academic support and made sure they had test-taking strategies and studying strategies. We provided social support, Sunday dinners at our homes from faculty. And then also they had an independent academic coordinator that really met with them quite frequently to support their academic success. Next slide, please. Again, the pre-entry programs, so they came on campus before school started, a couple of months before, that really promoted their socialization to the school. They got additional shadow experiences. They had community engagement. They were able to work with other graduate and student mentors. So it really just allowed them to address some additional barriers. They met with the financial aid. They were able to get their apartments, meet with their faculty mentors early. And then we provided a social worker as well. They did a lot of team building. They got some mindfulness seminars because we wanted to address any issues that were associated with anxiety. And then just some transitioning seminars. Next slide, please. And these are just some pictures of some of the experiences that they did, such as shadow experiences. We also made sure they did community experiences for giving back. And then of course, team building. Next slide, please. Our community was fully engaged with this, our faculty, our administrators, and then also our community. Next slide, please. These are just some of our outcomes. Currently, we have 44 students who have graduated from Duke or other nursing programs. Several of these have graduated, as you can see, from higher level education, including nurse practitioner program, CRNA program. We have several MDs, and we still have almost 20 that are currently enrolled in our undergraduate nursing program, and many more that are currently in higher level education nurse practitioner programs. Next slide, please. Our current initiatives, we're developing some bridges between one of our local HBCUs. We have developed a bridge with our undergraduate program, and we are piloting that to see if this bridge program will be successful, that we can transition that bridge. Because we are an accelerated program, our students have to have a bachelor's, so we really can't have an articulation type agreement with a community college, but we can have a bridge program to another bachelor's degree program. So we are looking forward to transitioning this to one of our local HBCUs and having that bridge to them. And then also making sure that we have some standalone courses that will be a full curriculum for cultural and social determinants of health. Next slide, please. And these are just some of the faces of our graduates from our programs. And I also just want to give honor to Fitz, who I truly adored and admired as my mentor. Thank you so much.
Next is Dr. Ephraim Talamantes.
Excellent. Well, good morning, Health Equity Warriors. Really excited to be with you. I know we're in different time zones and wanted to share a few thoughts and I'll also encourage some questions, and I'll also share some links throughout the presentation or shortly after with referencing some of the materials I'll share today. So thank you. I'll be talking about closing the healthcare workforce gap. Really, again, indebted to Fitz and all his work around health equity, and really including me as part of this family, this greater family out there. Really appreciate all of you. So we'll go to the next slide. So as a practicing internist, one of the key ways that I've began to understand institutional racism is obviously through the lens of our patients. As our patients access care as providers or clinic teams, we recognize the differences in their backgrounds, where they're coming from, whether it's both educational or just our own understanding or maybe misunderstanding of their culture or language. And more importantly, our bias around what we believe our patients need based on their race. And we know that, as you've heard this morning already, that this is historical. And we really spend a lot of time on trying to undo a lot of misconceptions or I would say misunderstandings around our role as health practitioners, providers, clinic teams, in trying to make sure that we meet our patients where they are, really driving towards equity, but more importantly, understanding that our patients have their own understanding of who we are as physicians, especially if we're physicians of color, whether Black or brown. Our patients have an understanding or maybe misunderstanding as well of us. And at times we have to think through that. We may hear overtones of discrimination from our patients, and vice versa. We also may perpetuate or share opinions with our patients, our clinic teams around race or comments that bring in race into question. So really important work, and it really drives a lot of the work that I'll be sharing with you today. We'll go to the next slide. All of us are familiar with this depiction of equality, equity, and justice, and I'm not going to go too much into detail, but one of the key things that we've all seen is that there's been an evolution in our thinking, especially during these very stressful times, this crisis that we have in this country, and that racism and institutional racism, that ugliness has really reared its head in many places, and places where we've been left to take care of communities that are severely impacted by COVID. And there's really little to no infrastructure. So here at UltraMed, we serve primarily in Southern California, 300,000 patients. 80% of them are Medicaid and 20% uninsured. And these have been some of the hardest hit areas. But one of the key things that we do as scholars is we continue to challenge our thinking. And so I want to just focus here and share that this depiction itself is perpetuating its own institutional racism in our own ability to understand what equity and justice is truly about. And that's because the three individuals in this picture inherently, as we look at this and we really analyze this, we're already attributing their inability to watch the game due to their height. So it's a biological explanation to really understand what is the barrier that they face because of their height, a biological factor. So I was, always curious, never bold enough, but Dr. Barcelo, if you go to the next slide, in his recent academic psychiatry commentary, really described this well. And that is that as we think about some of the challenges that our students are facing, or even our providers, clinic teams, those that identify as people of color, is that it's not about height, it's not a biology as much as all individuals in this case are of the same height. And you can sort of make your own conclusions as you look at this picture of what race they are. But it's the reality that some of us are in a ditch, and the more we dig, we just go deeper. And some of us are on a pedestal, and no matter how much we fail, we're still gonna be above everybody else. And then there are those, some of my brothers and sisters that I've left behind in my own communities that were chained, put into prison, lost their rights, their ability to come back and integrate into our community. And many times I would say many of our students feel the same way. And that's really what inspired a lot of my work, Mi Mentor, a national organization that I'll share more about. But I just really want to thank Dr. Barcelo and his team. And I'll share the link so that you're able to read this article. And it really challenges our notions and understandings based on the pictures, and I'm a very visual person, that we use. And sometimes those pictures may actually be perpetuating racism itself. We'll go to the next slide. So I had the privilege of putting together a commentary with Fitz, really looking at where are we today compared to 1997. We know 1997 was a huge hit in specifically to medicine. California is one of the #1 exporters of pre-meds or medical students out there. And I'm sure other professionals, other health professionals as well, but we looked here specifically at medical students. And in 1997, what happened in California was that there was a huge anti-immigrant, anti-people of color leadership in our legislature, who was a governor, legislature, who was pushing anti-affirmative action. And so what we see today, moving to 2017, or making a comparison, is that overall, when we look at our medical schools, whether medical or MD or DO, there's a severe underrepresentation that continues. And if anything, we're concerned it's getting worse. And really, we pulled all the numbers from both the Association of American Medical Colleges and ACOM, the DO governing body. And we looked at these and compared them. And really, when we look at our populations and who we have to care for, there's so many more patients of ours who identify as underrepresented minority groups. Obviously, in some cases, they're the majority. But we are severely concerned that our whole admissions process, the way we think about the students and this idea of distance traveled, that it's not allowing for us to really create a more equitable process for our students to get admitted. And also, once they're admitted, as you heard earlier, what we do to really support them through the whole process. So this gives you a good sense that, we have to do more. And I really appreciate being part of this national conversation and supporting this. And here, for the next slide, if you can move to the next slide. So what does that mean? So when I started mentoring early on in my career as a undergrad student, trying to get high school students to come into undergrad, or when I was a medical student trying to get students to go to health profession schools, medical school included, was that I was mentoring many students who were starting off at community college. And that's because we know that it's a more affordable way for us folks who come from low-income backgrounds to really get our education. And, during the time of, obviously, the prior recession, there was actually an actual uptick in the number of students going or selecting, even though they were admitted maybe to a four-year university, they were selecting to go to a community college because of its affordability. And this is data from the Association of American Medical Colleges. So we saw that medical school applications from those students who once attended community college were going up. And this is important to keep in mind, because if we're going to be having students come from the community college, well, what does a more equitable process for them in selection look like? Are they actually getting in or not? And we'll go to the next slide. So one of the first early publications really allowed me and our team to really describe, well, who are the students who are attending community college and where do they end up? Are they ending up in medical school? Are they ending up in a specific setting like primary care? And we found that 28% of our medical students attended a community college. So a third of the students at some point in their training up until medical school had attended a community college. But it was a little more complex than that, is that some students in high school actually attend community college because they don't have the advanced placement courses, or they graduate and then go to a community college and then transfer to university. And then we have students who are career changers who finish the university and then go back to community college and get the courses they need to then apply to medical school. And it was really important to tease up, these different paths, because every path then requires us to have a real effort and really pushing us to say, well, what are we doing at the community college to recruit individuals to medical school, and what are the structures we have to put in place in our medical schools to support them? We'll go to the next slide, and I'm almost done here. So again, we know clearly that the students in medical school today who went to a community college are also Latino, Black, Asian, white, and they're the first in their families often. And so this was important because when you have students who come from, for the first time, they're getting into college or going to medical school, again, it gives you a good sense of the type of mentorship and support they need. We'll go to the next slide. And really, so what happened? So we followed this cohort and looked at where they actually matched. And again, the adjusted odds ratio for those students who went to a community college, who went to medical school, got in and finished, and then went on to residency, was that they were going into family medicine. And that's important, again, because of all the shortages. And here at Ultimate, we experience it all the time. We're always looking for primary care practitioners because we don't have enough, right? And so we know that these students are going to come back to the community and serve. And last slide. So Mi Mentor, where does Mi Mentor play a role? We started with a very small group, maybe 400, like those participating today. And today we have 11,000 individuals in our Mi Mentor app, which is a smart app on your phone. And you can also access it online, mimentor.org, and download it to your smartphone. And we have real-time opportunities. We're sharing advice. And we really do target our Black and brown students who, again, many times are the first in their family. they're overcoming hurdles. They're trying to get good advice, and they want to be supported, and they want to talk about the experiences they experience overcoming institutional racism, and they want to be part of the solution. And that's what I'll leave you with, is that what's been most inspiring for me is all the lessons I've learned from all these students in creating this national platform for mentoring. And the mentors too, is that we're all committed, and I really appreciate being able to recommit that we are addressing, calling it out, institutional racism, really using an equity lens, and actually really challenging our status quo as how we think about it, and evolving and moving forward so we can create a more equitable healthcare delivery system that can meet all the needs of the patients I talked about earlier. So thank you.
Thank you. Our next speaker is Dr. Demetria Rankin.
Good afternoon, and thank you for having me. I'm very happy to be here. And, you know, to be completely honest, we all know that the past few months have been very challenging and unique for everyone. And so the admissions community is not exempt. And so in my role as Associate Dean for Admissions at my institution, basically, I view this role as essentially the gatekeeper for the physician profession. And so it is very important that we keep this in mind. And so we know that the COVID-19 pandemic has disrupted the application, selection, education, and training processes for the nation's physicians' workforces in ways like never before in the history of organized medical education. And additionally, the urgent need to address systemic racism has sparked an important national discussion about racism in America. And again, admissions is not exempt for this. The work that we do in medical school admissions is absolutely impactful for our profession for at least the next 30 or 40 years for each individual that becomes a physician, because this is the usual practice span, or years of practice that a physician remains in practice. Given this, it is essential that we train highly qualified students from diverse backgrounds so that we can be impactful in addressing healthcare disparities. And so, speaking from the perspective of our school and the admissions community in general, we've seen an evolution in the admissions process at our institution, specifically because of two discrete efforts. And those efforts include, number one, implicit bias recognition, and then second, the use of holistic approach in admissions considerations. And so just to expand a little bit upon implicit bias, recognition of unconscious implicit bias as a factor for how we make decisions is very, very important. The cognitive sciences have demonstrated that human behavior, beliefs, and attitudes are all shaped by automatic and unconscious cognitive processes. And biases does not make anyone a bad person. Much like biases in scientific research, an awareness of this bias can reduce their effects and improve the objectivity in medical admissions. And so when it comes to individuals who serve as gatekeepers for the medical profession, it is important to develop an awareness of these implicit biases, which may influence the behavior of the admissions committee that could result in preferential treatment toward or against specific groups for which a bias exists. And in fact, we actually completed a study at Ohio State where we looked at the admissions committee and we asked about implicit biases as well as explicit biases. And this was done several years ago, back in 2012. And it was apparent that, like the general society, the members of the committee held some biases. And so with efforts to mitigate these biases, the subsequent year, that class that matriculated at Ohio State College of Medicine was one of the most diverse classes. And it wasn't because of changes in the demographics of students that applied to our particular school, but it was because of these strategies that we employed to mitigate the implicit biases were several-fold. And so this impacted the experience of the candidates for our school. And again, it resulted in a very, very diverse, one of the most diverse classes up until our history at that particular point. And so the strategies that we employ to mitigate implicit bias are several-fold, but for brevity, I will include that admissions members taking implicit association testing prior to the beginning of interviewing candidates with self-reflection on the results, In addition, providing strategies for the committee members to be able to mitigate those biases. And those strategies include common identity formation or an exercise of simply considering the opposite. And so when you have a student that, oh, let's say the student in admissions, we're considering for admissions, got a B- in organic chemistry. And to think that there's no way that this person could go on to be a successful physician is not necessarily being holistic in your approach, because there's probably other factors that can be considered that demonstrate an ability to be persistent, an ability to be and demonstrate that intelligence, especially in research or other areas of the application. So the exercise of considering the opposite and looking for other information that might inform a different conclusion is something that we practice with our faculty members. In addition, the use of holistic review in admissions process. And so holistic review means that we assess a potential medical student's experiences, attributes, and their metrics in an equally weighted manner as we consider how they will support our mission of recruiting highly qualified students to further leverage the benefits of diversity, equity, and inclusion in the physician workforce. We believe that we must actively avoid an old and outdated mindset of anchoring a candidate's potential for success in medicine to MCAT scores alone, because we know that it takes more than just a good MCAT score to be a doctor. In fact, at a certain point in our interview process, another way that we reduce bias is that we remove the metrics from the interview process, just to reduce this anchoring bias. And this is not to say that having good grades and having a strong performance on either the MCAT or your GPA are not important, but once a student has met these metrics, it really allows our admissions committee to further explore those particular experiences and attributes of a given candidate in consideration for admissions. And so as a member of the admissions committee, we must be intentional about our efforts to address healthcare disparities. And it begins with improving and expanding who gets into medical school while valuing the additions that each student adds to the medical community. And with that, I'll pause and pass the baton.
Thank you. Our next speaker is Dr. Valerie Romero-Legat.
Hello, good afternoon, and I'd like to thank the Fitzhugh-Mullen Institute for the honor of being here today with all of you. And I'm very excited to share about our Health Careers Pathway programs and lessons learned. So I'd like to begin by offering some context. Next slide, please. We are the state's only academic health center. And as you can see from this slide, we're a very rural state with a little over 2 million people spread across 121,000 square miles. Many of our areas are considered frontier. We are a majority minority state, and we are also home to 23 federally recognized tribes, sovereign nations. And our rural areas in particular have significant underserved health and healthcare needs. We have 32 of our 33 counties designated health profession shortage areas. These areas have very large minority populations. Next slide, please. One of the critically important ways that we respond to these needs are our communities to careers. So we are committed to growing New Mexico's diverse healthcare workforce in partnership with communities across New Mexico to create sustainable K-12 health careers opportunities for the diverse youth of New Mexico. And as our logo depicts, our little communities to careers logo, we really believe in growing our own diverse workforce, but just as important, more important, is that these students return to their communities to serve their communities. So in the spirit of growing our own, as you can see on this slide, we've evolved these highly integrated pathway programs from our elementary schools into the health professions. And I cannot emphasize enough the importance of beginning pathway programs as early as possible and offering as many different health professions as we can. And it's so important, especially for our first generation students, to see that here are some of the things that you can be, right? To begin dreaming and striving to achieve these dreams of a health career. So other key components to these programs we'll talk about a little later, but also most significant is that these programs must be in our communities. Also important and fundamental to the programs, of course, is academic success, but also personal and professional development of our students. And one of the major goals of our Communities to Careers programs in Diversifying New Mexico's health professions is to really reflect the populations we serve. Next slide, please. The results in this slide show that our programs overrepresent the underrepresented populations in the health professions. And this happens because of our partnerships, most definitely, but we're intentional about recruiting students and working to retain them from our communities. And you can see that we reach a substantial number of students each year, and over half of these are our first-generation college students. Next slide, please. I talked about the importance of having our programs in our communities. And we've had many of our programs across the areas that you see here in color on the map of New Mexico. And now with our HRSA HCOP federal funding, we've been able to develop and operationalize this concept of regional hubs. So the idea here with these hub sites are to concentrate several of our Communities to Careers integrated pathway programs in a manner that allows us to serve an entire region rather than certain isolated pockets of areas. So we're building an infrastructure across the state, and our hope is that in the very near future, we'll be able to continue to expand across where this whole map of New Mexico would be colored. But critical to the success of these regional hubs are several key components. And first and foremost, we have to have local on-site regional hub teams. So hiring people from the community to lead these programs is essential. They know the community, they know their students, the partners, their assets for the community, they know their needs and their strengths. They're the drivers of these programs and really help us provide and create and optimize opportunities. And this also makes a difference as we work to achieve sustainability, which is an ultimate goal as well. Other partnerships, our partnerships and relationships, as we've heard throughout the day from my esteemed colleagues, are just essential as well. So working with our local academic institutions, K through 20, our community colleges, educators, branch colleges, post-secondary ed, elementary, middle, high school, our community partners, community health councils, business and private public entities, AHECs, public allies, and engaging our families, a critical component to the success of our students as they go on in the educational process. And community clinical partners, our FQHCs, individual and group practices, labs, hospitals, and our local community health professionals. I'll never forget as we were first going into our communities with our programs, because early on we had been Albuquerque centric and medicine only. And the local health professionals, our site coordinators called us and said that the local health professionals had been so excited that they had been invited to come into the schools. They hadn't realized and never been invited before. So it's also opened up some mentoring and future job opportunities for our students. And engaging our health profession students in any of the communities because it's so wonderful to see our students and have the students in the programs be able to see these incredible models. So the role relationships, again, are very critical. Next slide. I've talked about our Communities to Careers pathway programs, but I really want to acknowledge that, of course, we have incredible other programs across the health sciences that really, a multitude of programs working to diversify the health workforce. And I just wanted to mention a couple of them here. Our College of Pharmacy program with their early assurance plan that they've launched and really stating the importance of reaching back earlier in the pipeline in the freshman year for their students. And also the importance, again, of having programs in the communities where their students are from. Our College of Nursing program had an IHS Indians into Nursing program, American Indians into Nursing, where they substantially increased the percentage of the American Indian Alaska Native students in the College of Nursing at the University of New Mexico. And then our BA to MD program, our partnership program with the main campus, College of Arts and Sciences and the School of Medicine, really looking to address the physician shortage by admitting a diverse class of high school seniors who are committed to serving our communities of greatest need. And they've been very successful in both geographic and racial ethnic diversity, as you can see from this slide. Thank you. Next slide. And I really want to call attention very briefly, would love to talk about it more, but building the next generation of academic physicians, because this program is the program that works to diversify our academic faculty, which is critically important, and they definitely need diversifying. So it promotes, diverse trainees' awareness of, interest in, and preparedness for academic careers. Always a primary goal is to have knowledge and skills to promote pre-faculty development. An excellent resource in this book and the launching of the new National Center for Pre-Faculty Development this year was launched with 25 inaugural members, again, supporting institutions. Next slide, please. And finally, in this slide here, I just want to say this is why we do the work that we do. This is what these programs are all about. We all have these kind of stories. This is what we're striving to achieve. Next picture, next slide. So Dr. Garcia is one of our students in 3 of our education pathway programs. Next slide. And she got into our School of Medicine, our family medicine residency program. And then this next slide that you see up here is the banner that was across. Her first job was in Portales, Eastern New Mexico. She drove into town and she sees this huge banner across Main Street, Portales. And she was just texted me, sent me a picture right away, and she was so excited. And she said all of these young little students were running up to her, and these young little kids in the community running up and saying, "Doctora, doctora, we saw your picture. Are you going to be my doctor?" And she was just so touched, like I said, and just shows you and just the impact and how important it is for our communities with our different health providers. And then as most of our health profession students, Dr. Garcia has continued to give back, and she precepts students in the programs that she was in, and she has done this year after year. And then last slide, she has most recently in the last year opened another clinic right nearby in her hometown of Clovis, New Mexico, serving the community again. And as you can see from her quote here, really feeling like an impact she has is filling a cultural void with the Spanish-speaking individuals in her communities. So I end with this story and because it is what it's all about. And this is how we really advance health equity and make a difference in the health and well-being of our communities. Thank you.
Thank you. So I want to thank all 4 of our panelists. You've gotten us off to a great start, and the work that you're doing it's not just commendable, but it really does set the groundwork for us to think about how do we move toward health equity in health professions. I do want to say one thing is that the individuals on the panel are physicians and represent nursing and physicians, but the health professions are broader, and all their programs are aimed at people entering in health professions. They're not limited to only physicians or nurses, which is, I think, a very important thing to recognize. Especially, I'm a physician assistant, and I recognize that this is really important. So we're going to start by sharing some questions that the folks in the audience have sent out. I'm going to ask Chelsea if she can address can give us one of the questions, please.
Yes, thank you for all of your great questions. I just want to briefly mention that this session is being recorded and will be emailed to everyone following the presentations. And if we don't get to your questions out loud, we will answer them and post them on the website. So the first question is from Gerard Jolly. It was posed to Bridget Carter. And there was a response to this, but I think it would be relevant for anyone who would like to respond. And that question is, how do you determine benchmarks for success in achieving a diverse student population or workforce?
Yes, and my answer to that was the benchmarks that we use are really based on the community that we serve. So for our undergraduate program, we use the benchmark of our local community. However, when we look at our graduate programs, we go based on the United States. So it just depends on which program we're looking at. So if we're looking at our doctoral program, again, we use maybe some of the AACN data. to look at, worldwide. So it just depends on which program, but we really are looking at the communities that we serve in terms of the benchmarking.
I'd like to just add a little bit as well to that question, and I agree with Dr. Carter as well in terms of depends on the community we're in and looking at those benchmarks. We also look for our benchmarks, the parts of the success in students going on in their educational career. And we've heard, of course, the importance of education. So we look at students getting into high school, graduating from high school, graduating from college in 4 years versus 6 at times. And then, of course, going on into the health professions. And we follow in that way as well, because that's important successes for us. And we can compare those to the state's percentages and cohorts within those same regions.
And just to add to that, in terms of MD programs, the AAMC, which is the governing body, and I imagine other health profession programs, there's been historical data about performance on examinations, which has been used to try and extrapolate or predict subsequent performance on various exams. And so I think it is important to use the full gamut of these testing parameters to be able to really, because pass is pass. And so there's a saying that, and I'll probably, no one hopefully will criticize me for it, but what do you call the person that gets a C- in medical school? You still call them doctor. And so I think it is very important that we use the full scale of these various testing parameters to make sure that we are, again, that's only one piece of the picture in terms of predictors for success.
Thank you. It's getting close to the end. Can we squeeze one more question in, Chelsea?
Yeah, so we have a question from Kat Ogle, and it was posed to Dr. Rankin. How can we create faculty development tools to enhance holistic review with regard to applications in medical school and residencies?
I think faculty development is very, very important, again, because these are the individuals that serve on the committees for recruitment efforts. These are the individuals that teach in the various curricula. And so it is absolutely important. And I think that is actually in light of the awakening that lots of institutions are engaged upon, especially, a lot of institutions, it is going to be having that conversation about what the students needs, what the faculty needs to be able to thrive and to interact with our learners is going to be very important. And so it's absolutely required and essential that faculty development is a part of the agenda and the career for each faculty members.
Can I add something to that? Because, in nursing, holistic admissions has become actually a very critical part of our agenda. And for our admissions committee, one of the things we see this as accountability to is part of our admissions curriculum. We need to make sure everyone who enters into our admissions committee that this is part of their orientation. It's part of our faculty orientation that as soon as you walk into the door as a faculty member, that this is part of what you learn about, because a lot of people don't understand what holistic admissions is. And they really don't understand that this isn't about pulling people from the top of the list and putting them somewhere at the bottom of the list. So we need to actually explain this process to them early on as they enter into our institution. So I think it's really important to make sure people understand that this is part of an institution's core value. And so if it's not, that maybe that's not the place for them to be.
And Howard, before we
go ahead.
Before we end our time today here as well, I did want to speak, I know on behalf of all of us really here today too, in acknowledging everything that we're doing here in the holistic review and the pipeline programs of the Mi Mentor, and every single program that we do is critical that the offices of the people that we work with who do this work and are passionate and committed to this work are really, you know, at the end of the day, the key drivers in all of this, and our teams and our offices and those people who do this. We couldn't do anything, you know, anything without them. And I think a lot of us, like, we always assume that, I know we do, but I really, on behalf of all of us, are giving that shout out to the teams and the people who really are the ones oftentimes behind the scenes, but so totally committed and really making all of these programs and these outcomes and the students that we see into our health professions successful.
Thank you.
I'll just share. It is a journey. I would say my experience at the University of California, Davis, the Center for a Diverse Healthcare Workforce. There was a lot of evolution in our own thinking, and also challenging the models we used around selection, and actually putting them to the test, and then looking at, did we predict right? Let's look at our historical data. And you know, oftentimes those models are wrong. What happens when we predict someone's going to fail and they pass? And then we say, oh, well, you know, there's other sort of factors. But when we predict someone who's going to pass and they fail, we really, you know, bring that back and just, you know, really demolish the whole process. Say holistic admissions is no good. And I think that's where, you know, there's really got to be a better balance. So thank you for that.
All right. I would like to thank everyone. I would like to thank Dr. Carter, Dr. Rankin, Dr. Romero-Legat, and Dr. Talamantes for sharing your experience, your thoughts, your insights. We send you positive energy as you continue your work in this area, and to all your teams and to all the teams who are working on this. I want to thank everyone. We're going to take a break and resume back at 2:45 Eastern Time, and for the next panel, which is going to look at the changing experience of students and faculties of color in health profession schools. So you can stay on, or you can rejoin through the link. Thank you very much.